Good afternoon, everyone. My name is Dr. Natasha Ratnaraja, and I'm an infection specialist at, sorry, my video's not working. I'm an infection specialist at University Hospitals Coventry in Warwickshire, and I am the chair of the Specialty Advisory Committee for Medical Microbiology and Medical Virology at the college. Thank you for joining us for today's webinar, Fungal Update, Fungal Infections and Haematology-Oncology Patients. Pleased to know that we have 174 people registered, which is very good. Today's webinar will run up to 1 hour and will include a short presentation by our speaker, Dr. Rena Richardson. We will then have a short Q&A session. To ask a question, please use the Q&A function at the bottom of the screen. There will be no chat function. Please note this webinar will be recorded and uploaded to the RCPAF website in the coming weeks. Attendees can self-credit 1 CPD point for attending today's webinar. So I'd like to introduce Dr. Rena Richardson. She's the clinical head of service for the Mycology Reference Centre in Manchester and a member of the infectious diseases team. She's internationally recognised for her expertise. She's a senior researcher, educator and clinician in the field of fungal infectious diseases and is well published. So I'm going to hand over to Dr. Rena Richardson now to start the talk.
Okay, that was a lot of clicks. Apologies for the delay. So yes, welcome from me as well. And I hope you all sit comfortably and are ready for a fungal update. It's very exciting times in mycology at the moment. A lot of things happening, new pathogens, new drugs, and we have to develop a bit of new thinking as well. So I'm going to do a general fungal update as requested, but I'm also going to focus on haemato-oncology patients and that setting, as that's where the most severe infections most commonly are seen. These are my disclosures. I spread myself thinly, so no bias there. So I know you all know that there are loads of fungi in the world, but yeah, over 100,000 species, but only less than 500 are sort of broadly associated with human disease, and less than 100 can cause infection in immunocompetent hosts. I say only and less than, but realistically, I think this is the main point of this, is that we tend to think that fungal infections are infections in the immunocompromised, but that definitely is not the case. There are loads of pathogens, fungal pathogens, that can cause infections in anybody. We also often think that, yeah, immunity is important, and that is our wonderful immune system that keeps us protected from the fungal pathogens. But unfortunately, it's not that fancy. The main factor protecting us from fungal infections is actually a weakness of the fungi, and that's their poor thermotolerance. They can't cope with 37. Obviously, less thermotolerant species can cause infection, for example, in toenails and the cooler parts of the body. The key thing what's happening now is that thermotolerance in many fungal species is evolving due to climate change. And more species are reported in human infections we never thought could do that. And in our lab, we see this all the time. We identify and grow, because we grow our, as mycologists do, we grow our or culture our plates in 25 and 37, and we increasingly identify growth in 37, which when we sequence them, we're like, can't even pronounce the name of the fungus, never heard of it before. So environmental fungi growing in human body temperature is a new phenomenon. And this is exactly what happened with Candida auris. We thought we got a new fungal species, new Candida species, in 2009. But now that we have looked into it, it actually is an old environmental yeast which just became thermotolerant. And as life out there is tough in the swamps of India, they are tough fungi. So they are multi-drug resistant to begin with. They are nearly as virulent as Candida albicans, which is the most virulent of Candida species. They form biofilms as readily as Candida albicans. They tolerate drying, and that's a general feature of yeast. We all know about dry yeast and how you can use it for cooking. So give a bit of water and sugar, they grow happily again. Yeast are tolerant to alcohol. That's a general feature as well. Some brewers have noticed that. Low or relatively high alcohol levels, like in hand gels, may not always be effective. And unlike practically any other Candida species, Candida auris can colonize environment, it can colonize healthcare environment and skin, and it's a completely new approach to things. So it's often referred to as the MRSA of Candida species, and that helps to think it behaves very similarly. And also when you do the swabs and other things for it, you just follow the MRSA thinking. But controlling is really challenging for all these reasons. And the first cases were reported from Japan in 2009, and then in Indonesia, India, Middle East, and South Africa, and finally South America. It was thought that that's the direction of travel for flu, that we believe that that it spread from country to another. However, now these genetic mapping has been done for the different outbreaks and the different isolates, and it's become very clear that they are completely unrelated, which is actually quite scary. The fact is that Candida auris evolved and developed thermotolerance in 4 continents, more or less simultaneously, after a couple of years of very hot summers. Obviously, from these original areas, it has spread to more northern countries, Europe and US, and in the UK we see all the possible clades of auris. So the reality is that it has happened once, and it happened many times for one pathogen in different parts of the world. So we have to be prepared for emerging new species. This has to change how we think about diagnostics and management. We have to be prepared for the unexpected things. Very targeted, narrow approaches are not the answer. Now, I'm sure you all know about the WHO coming up with the fungal priority pathogen list now a year and a half, 2 years ago nearly, and listing the pathogens with most concerns, and the list here was driven by antifungal resistance, and that being top priority. So the species in the critical group are all those where antifungal resistance is seen repeatedly, and where it is definitely clinically important. So what are the antifungal agents we have in our hands? I'm sure you all know about the currently licensed antifungals, ranging from azoles, poloines, echinocandins to our terbinafine and flucytosine. There are antifungals in pipeline. We have 2 completely new classes, or actually almost, there are 3 new classes, Iprexa fungab, olorofim, and fosmanogepix. I have been a PI for Iprexa and olorofim clinical trials, and they are slowly but surely moving forward in their registration. All of the 3 are now FDA registered already. And then we have oproconosol, which is a very odd drug with 180-day half-life, which is quite scary if you're allergic to it, but it could be used for long-term prophylaxis and so forth. Very, very odd drug. I'll cover the new antifungals later when we first discussed how we first diagnosed the infection. And also touch upon what the guidelines currently say about using the licensed antifungals. Antifungal resistance. Yeah, so the old thinking was that antifungal resistance does not really happen. And that was because fungi are eukaryotic cells, like human cells, have very strong DNA repair protein, mismatch repair protein systems. So they do repair their DNA mutations all the time very actively. And therefore, we didn't even think we needed to do antifungal susceptibility testing, because you do it once and you know what it looks like. And it's the drug company's job to do that. However, and that of course reflects innate resistance if from the beginning you are already resistant to it. But it has become very clear that there is acquired resistance to antifungals, and there are two main routes which are very similar to antibiotic resistance in principle. So you have your patient route, resistance develops in a patient during treatment, or environmental route, in principle sounds similar to One Health thinking with antibiotics of animal husbandry and use of antibiotics in there, contributing to more antibiotic resistant bacteria. But there are differences. So the patient route resistance relies on mutations and protein synthesis changes. Fungi don't do plasmids and don't change in their DNA material that easily, or they don't do plasmids full stop. So mutations have to happen, and before that can happen, it's almost like with cancer cells, you have to first lose the control of your DNA repair proteins, and when those mutate, then additional mutations start to remain in the genome and can affect the critical sites. And it's a stepwise thing, and therefore screening for antifungal resistance using molecular methods is a multi-target, often requiring sequencing rather than a simple PCR. So these are the mechanisms there are. The third mechanism is polyploidy, which obviously you can't see in prokaryotic cells. So polyploidy means that we all fungal cells have the natural number of copies of chromosomes. So you can have haploid, diploid cells typically, and the polyploidy is when the cell starts to divide by the nucleus dividing, but then the cell stops dividing. So you end up with double number of chromosomes in a cell in the nucleus without actually the cell dividing. And that means that there is, you don't actually have to, the chromosomes don't have to change, mutations don't have to happen, but your protein synthesis for certain proteins goes double automatically because you have double number of chromosomes. And that is a very tricky one, and fungi do it very happily and quickly. And it's difficult to detect by susceptibility testing, because when you take the antifungal pressure away, why would they remain in their multiple copies? So they behave like they never did anything wrong, and you can't detect it. So it's very tricky. Environmental route, instead of animal husbandry for fungi, the main route is really agriculture, use of azole pesticides in agriculture particularly. Many of the sprays that we use are actually azole structured, and there's cross resistance between medical azoles and the pesticides. And that is well described in the Netherlands, where they dip their tulip bulbs into azoles before growing them, and then Aspergillus in the soil selects out to be resistant, and then wind spreads them all around. And there are hospital areas where all the patient gets automatically double therapy with azoles and amphotericin B to cover for azole resistance. So that is happening and well described in the literature. Additionally, biofilm formation is a very important antifungal resistance mechanism for fungi. All fungi are wannabe mushrooms. They want to be something bigger, and when they given half a chance, they form a biofilm. So there is also similar link with your Staph aureus. Yes, so fungal biofilms happen and are wherever. They can happen on artificial materials, but they also happily can form a fungal ball in a cavity that is not draining well. It can be your paranasal sinuses, or a preformed cavity in your lungs, or wherever fungal spores may get trapped. Diagnostically, it's important that these are persisting source for fungal antigenemia. So if your galactomannan remains high, your immediate think must be, where's the fungal biofilm? Why is it? It's shedding these antigens persistently. It's also important to say that fungi are very sociable. They happily form multi-species biofilms with bacteria and protect them from antibiotics. So they are performing like a extra skin over them. And mixed infections are definitely associated with higher mortality, well published as well. This is a sort of so-called Casa-de-Val curve, summarizing. This applies to many other, not just fungi, but Arturo Casa-de-Val from New York was and is very passionate about fungi, so he describes this for fungi mainly. But basically, the whole Casa-de-Val curve idea is that the outcome that happens after exposure of a pathogen or opportunistic pathogen to the host, human host, depends on the immune response. And if you are slap in the middle, the outcome is colonization, and the weaker you are, more left you go, you start to see damage, and that's caused by invasion of that pathogen into tissues, and finally you cross that disease threshold. Stronger is not better, so the further right you go, you start to see damage again, but this is not now because of invasion of the pathogen into tissue, but it's caused by the inflammation, the immune responses to the pathogen, which are overly strong. So this is what we look at when we look at fungi, and there in the same review, that is, the reference is there for you. You can see that for example, for Aspergillus, with intact immunity, you may be asymptomatic in the middle, but if you have impaired immunity, you get invasive aspergillosis. Whilst if you're to the right with the strong, overly strong hypersensitivity kind of atopic setting, you get allergic bronchopulmonary aspergillosis, APPA, or allergic fungal rhinosinusitis. With Candida, similarly, you get disseminated disease when you go to the left, or oral Candida is only seen in some sort of immune failure, whilst to the right, vulvovaginal candidiasis has a component of hypersensitivity in it. So oral thrush vulvovaginal thrush, not typically seen in the same patient. So this describes fungal pathogens quite well, broadly, whatever you have, and it's a really nice readable review for you to have a look at. It also lists various non-genetic factors that are associated with major human mycoses, and I've added the CAR T cell therapy there. That generally fungal infections are quite rare in that setting. Increasing number of reports there are about it, and often during the therapy rather than long term. But it's fungal defense in the body is very much neutrophil driven. T cells are important, so B cell defects are less associated with disease. But it's important to note that different immunity components, when they fail, they put you at risk at different fungal infections. Not Candida is not seen with all of it. For example, reduced interferon gamma activity it's not associated with Candida. It's more Cryptococcus or other things. So it's very specific, the defense mechanisms there. But then looking at the reality where we live, so in the UK, the main invasive fungal infections are candidemia and invasive aspergillosis. And we know that most cases of candidemia are seen in the ICU or in association with GI trauma or surgery, as everyone is colonized in their gut. Invasive aspergillosis, on the other hand, is, yes, also seen in the ICU, but far more commonly seen in haematology-oncology or transplant setting. And the numbers here are UK prevalence figures. Pneumocystis is coming as the third most important invasive disease. And we see it increasingly and almost more than previously, clearly in non-HIV populations of post-transplant patients and during chemotherapy, which is very important diagnostically. So how about hemonc? What kind of infections we see in that setting? And it's the same. We have Aspergillus species and Candida species, Candida albicans particularly, which is the most pathogenic of them. But we do see increasing numbers of non-albicans Candida species or rare yeast species like Trichosporon, which is on the plate below, and also non-Aspergillus molds, Mucorales and Fusarium species, mucoplate, the fuzzy one on the right below. So these are the species, these are the fungi we need to think about in hemato-oncology setting, so slightly more broadly. So where do we see these infections? So if you look at the top four here, you're really in allogeneic stem cell transplantation setting, or ALL, AML, and then autologous stem cell transplantation. Those are the main four that we can focus on. And if you look at those four, this is Australian results, but very similar to what we see in the UK. And you look at all these four groups, they don't massively differ from each other. So the main pathogen is invasive, or disease is an invasive aspergillosis. We see a little bit of mucormycosis, but very little cryptococcosis. So Candida, obviously, second runner in this setting. And if you think of the timing, and this is now very relevant for many of these, particularly molds, they are environmental. So the question is, where do these patients get their infections? Do they get it from the hospital? Are they hospital acquired? Or are they still vulnerable when they go home? And many people may go to quite challenging accommodations with mold growing on the walls. So does our responsibility end at the hospital door or not? This has been discussed. I'm on the HIS, the Hospital Infection Society Aspergillus guideline group for environmental exposures, and this is what we are just looking into, and it's quite clear that most of the cases happen within the first year in these 4 patient populations, but you can see that there are dots going up to 4 or 5 years. So it's not that the risk is over immediately after the transplant or within the first couple of months. Quite long whiskers there. And then just a list of, this is from the review, the references there for you. It's just listing the different small molecule kinase inhibitor licensed drugs that are being used, and looking at the percentages of invasive fungal infection incidence. Unfortunately, they are here. Well, usefully they are here in alphabetical order. So if you have to ever check anything, you find it quickly. But it's more difficult to look at where the high percentages are. And midostaurin is one of the biggies, and then ibrutinib is highly used also in the UK. And if we focus on that and look at so the incidence is 4% for that compared to midostaurin, which is nearly 11%. But ibrutinib exposes you to basically any fungal infection. It's a good spread of everything, which is a bit scary. So it's a very broad spectrum. But the key thing is that these NIBs are not all the same. So you can see that for some, there are reports of anything and everything. For others, it's just Candida or just something, or rare cases of Aspergillus. So you do have to check every time when you are asked the question. But anyway, as we all know that we are more and more going, that of course you start with guideline treatment, which is one size fits all, but we do have tools, and we must use the tools for targeted personalized treatment and treat the patient as they are. Can't cover everybody for Aspergillus and Mucorales and Candida and everything. So what are the diagnostic tools that we have? So this is a summary table, which is a bit oversimplified, but putting that aside, 4 most common species, genera of fungal pathogens there, and then the tools we use more, normally to diagnose them. I think the take-home message is that Mucorales is tricky. So we have very few. There is PCRs, but the sensitivity is tricky because of interaction with human DNA. We're not there yet with Mucorales PCR at all. Culture is they are very flimsy, lacking septae, so the cells break. If you get a BAL and you suspect Mucorales, instead of spinning and whisking and doing everything, just pour the BAL onto a plate. Don't touch them, they break, and you get a false negative culture. Whilst Candida aspergillus fusarium are tougher, they can be cultured, but they have their limitations. But we do have our antigen, beta-D-glucan and galactomannan tests. I'll go through them, how to use them, and then finally PCR for Aspergillus, important. For all of these, sample type is critical. You have to take the sample from the most affected site. So if you have a respiratory infection, please send in a BAL. If you have a disseminated infection, blood is fine. And with, of course, with respiratory samples, it's always the discussion, but is this colonization or infection? Now, broadly speaking, how do we choose in our diagnostic tests? We all know this. So we have rule out tests and rule in tests. In fungal world, that means that your rule out tests are used to stop antifungals after empiric start if you have a test that tells you with very strong negative predictive value that it is not it. So you can start treatment with gut feeling, this could be it, and then you start it, test result comes back tomorrow, next day, and it says no, you stop. So you can rule infection out. There are other tests that you could use to rule infection in, and that means that you are using it to start in treatment or withhold until it's positive. So these tests need to have high positive predictive value. So they have to be highly sensitive and highly specific. Whilst a rule out test needs to be extremely highly sensitive and can be overly sensitive, but the specificity is less important because you only use it to rule out, you only look at the negative results, basically. For all of this, the key obviously is the pre-test probability, and of course turnaround times define the usefulness and safety. I throughout these next few slides, I use these 3 balls or circles: sensitivity, specificity, and speed, and how bright the color is tells how good they are from that each perspective. So microscopy of tissue and BAL. We do this all the time in our lab. Our histopathologists send slides to us and ask for second opinion. And BALs, you look down the microscope. This is extremely useful way of deciding what's going on. You can firstly very reliably tell, yes, this is invasive infection. You see fungus in tissue, it is it. There's no speculation if like what's the CT value of a PCR. It is it. And you can also tell, of course, you can tell molds apart from yeasts, and that is considering treatment, very helpful. So it's very quick. It's really you can do it in after a few hours. It's out of the patient. Specificity is of course depends on who does it, but thinking of needs for deciding treatment, it's specific enough. You can tell if it's yeast or mold, and you can tell if the mold is mucor or not. And those are the key decisions, key aspects you have to know when you choose your treatments. So definitely train everybody, please train yourselves to do microscopy. Now, culture, of course, is standard method. We all do culture. And it's good to know that, just a reminder, bacteriological media are inferior. You get false negatives a lot, so you need to have your proper SAB plates. And depending what you're growing, it can take up to 2 weeks. Don't throw the blades away after 48 hours. You can find something very important in this patient group. And you can do susceptibility testing, which is really, really important in today's world. Sensitivity is an issue, and we all know that. Speed is an issue, but of course, highly specific. We can give a name and we get susceptibilities. However, what we've done here in Manchester, what we have started to do is what we call high volume culture. So we, instead of spinning down and doing as per the SMIs, culture 20 microliters finally of the spun down sample. We culture, for example, BA yellow sputum on 2 plates, 500 microliters each. So we culture 1 ml in total, and basically more or less like pouring it over rather than touching it anymore. So we could catch Mucorales as well. And this paper, you can find it on CMI paper a couple of years back now, shows that the sensitivity of high volume culture is similar or even better than PCR, Aspergillus PCR. So this is for Aspergillus. Plus, it's not specific to Aspergillus. So if you have, it grows Mucorales, it grows anything. And therefore, and it's cheap and cheerful. Anybody can do it. The only thing you need is 1 extra plate and using a little bit more of the sample. You have easy, straightforward, and then you start seeing positive cultures, and sensitivity goes up to same level as PCR. So sensitivity is good. Sensitivity of culture can be excellent for fungi. Specificity obviously is as good as always. Speed is still, of course, nothing speeds them up. They do what they want. Now, talking about candidemia next. So it's really important to remember that the concentration of candida in blood during candidemia is really low. Way over half of the positive blood cultures have less than 1 CFU per ml. So it's very low counts. And this is because candida forms biofilms somewhere in the body, and candida cells become released into the bloodstream very intermittently and transiently. And often like bits of biofilm go off, like biofilmemia, rather than single candida cells. This means that the sensitivity of blood culture is if you do normal 2 sets, is less than 40%. So it's about flipping a coin. So we know that a total of 60 mils of blood culture needs to be collected in a 30-minute period to achieve sensitivity of what we usually see with bacterial blood culture with 1 set. So so it's a really big difference. And this is what the new NHS England and Sepsis SMI are highlighting. Fill your bottles, the 10 mils, and take 2 to 3 sets. With candidemia, it has to be 3 sets, really. If you identify it sooner, excellent, but you're probably missing a lot. And you can just imagine, if there is so few fungal cells in the blood, it's going to be a challenge for PCR. There's always extracellular DNA and all that stuff, but in reality, if you copy nothing, you get nothing. So therefore, it's quite clear that we have to do something differently. One other thing we know about, these are old studies now, but you don't have to repeat it because it's not good for patient safety. So we know that if you start your antifungal treatment within 12 hours from drawing the blood that later becomes positive, the mortality is around 10–15%. But if you wait for the blood culture to become positive, normally at 48 hours or 72 hours, thereabouts, and then start your antifungal treatment, your mortality goes up to the 40% is the figure often referred to. So if it's 10% against 40%. So we know that early appropriate treatment is critical. And that's why all the guidelines now say, start with your gut feeling, but use a rule-out test that you can stop it the next day if that test is negative. And that rule-out test typically is beta-D-glucan test. Beta-D-glucan is a plant fungal cell wall component, not present importantly on Mucorales, cryptoblasto. Well, it's present on Cryptococcus, but it's hidden in that waxy capsule, so it doesn't become released. So it's been shed from these fungal cells into bloodstream during invasive fungal infections. Importantly, glucans are present also on lots of foodstuffs, cellulose filters. So sometimes if your patient is on a filter, it can cause positive signal. The surgical causes, TPN, environmental factors, it's a long list of things. Glucans are common in the environment. Practically, the bigger problem is antigenemia in the absence of fungemia. That means that you have your critically ill patient on ICU, they are septic and everything becomes leaky in sepsis. Your blood vessels can't hold the pressure and your gut lining doesn't hold completely the contents. So they don't leak enough so that candida cells would get through, but they leak enough so that the antigens get through. And that is a problem. And that's what you're measuring in septic patients often on ICU. So therefore, it is a rule-out test. Positive results should never trigger treatment. It's not to be, it's the specificity is not there. It's not to be used that way. And to make it more effective as a rule-out test, to reduce the number of false positives, you need to process the samples in your laboratory so that it's completely beta-D-glucan-free environment. So we use beta-D-glucan-free pipette tips, beta-D-glucan-free tubes, and we do not like to get serum samples that have been spun down, separated, and put into tubes not following that principle. And it's a waste of time, really, if you really look for that negative result and then we basically measure the contaminants. So sensitivity is excellent. Speed is excellent. We run this 5 times a day, so it's almost like CRP. Obviously, only the transportation is the issue, but the laboratory turnaround time is in hours. Specificity is we're not even trying to say it's specific to anything beyond what it measures beta-D-glucan. Galactomannan, on the other hand, is another antigen. It's very different. It's made typically from Aspergillus galactomannan. It's a sugar structure on the fungal cell wall, but it's present on many molds, so definitely it's not specific to Aspergillus. So it's a sort of pan mold or multi-mold biomarker, and it's present also in many foodstuffs, which we have had cases of ice lollies, hematology. Children undergoing chemo given ice lollies to help with the mucositis and in the mouth, and all in the sun get positive galactomannans because of guar in the ice lollies. Yeah, I think the important thing about galactomannan is to firstly, there are different sample cutoffs for different sample types, but at its best, it performs in neutropenic patients from blood and in hematology setting. The sensitivity and specificity are at their best. And you can see that in solid organ transplant setting, the sensitivity is only 41%, which is rubbish. So it really is a haematology-oncology setting test for blood. And even in that setting, 85, after 3 days of antifungal therapy, none of them are positive. So it is to be used in that in mind. So sensitivity is a question mark. Far more specific, though, to mold infections can be used that way, and speed is good. We run it equally 4 times a day, and you get quick results. It's very clear that blood, it has to be so. It's in non-neutropenic patients. Do not send your blood samples for that. I don't know how many 100 blood galactomannans we did during COVID from COVID ICU patients, and I don't think any of them ever were positive. You need neutropenia for the blood to be positive or severe immunosuppression of some sort. However, BAL is an excellent sample, and the ROC curve here very clearly shows the benefit of the right sample site. Aspergillus PCR, this is important. So in brief, this table, what it tells you is that Aspergillus PCR is approaching the perfect test. It has good sensitivity and specificity for both blood and BAL, and particularly BAL. And it's based on that and how quickly it can be done. It's the ultimate test in many ways for Aspergillus, if that's the one bug you want. And the EOTC is very aware of all the research, and they did their update a couple of years back now to establish the thresholds for galactomannan and beta-D-glucan in there, and the PCR tests. And they basically summarized that PCR needed to be added to the probable category of Aspergillus infection, and as long as the cutoffs are different. And they also say that beta-D-glucan should not be used as a rule-in test. It's always a rule-out test. And there were no changes otherwise in the classification for this. So important update in our thinking there. I very much like this paper. This is a lumbering paper on basically they did a nice study a couple of years back where they used a 2008 EOTC criteria for possible, probable, proven invasive pulmonary aspergillosis. But at the time they were already running PCRs, Aspergillus PCRs, but they couldn't include them in their classification. What they did then, after the new criteria came out, they added into their analysis the PCR results they had, and then looked at how the classifications changed. And as suspected, more cases were classified as possible, probable, or proven. So the purple became smaller, but then the possible group didn't change, but the probable group doubled almost. It makes you think that, are they now overdiagnosing? Is this useful? What are we doing here? And one way to look at it is to look at survival using the new criteria. And it's really important to say that when you look at the survival in patients where the criteria are not met versus the ones where it is met, the new criteria they lump together. So clearly that isn't you're not sort of overdiagnosing of something which is not it at all. But the important one was also to look at the cutoff for CT. So if you put CT of 36 there, that obviously depends on your CT kit you use, but in their kit 36, they could show that if the CT value was higher than 36, or 36 or higher, the survival was pretty good, which was in keeping with the fact that probably wasn't invasive aspergillosis. Whilst if you put it below, if it's less than that, survival was significantly lower. And with the similar numbers we always report for invasive aspergillosis. So actually the new classifications predict outcomes extremely well and prove that the test is doing its job. So there is no single test or sample that would be could be used to rule invasive aspergillosis in or out, although PCR is very much approaching it. We still need a combination of diagnostic approaches, and typically, of course, clinically, it's triggered by your CT findings. You shouldn't do a PCR. It's going back to the pre-test probability, choosing the right patients for the test. And the key is to identify the main site of infection and have a representative sample for the testing, and whatever is needed. In neutropenic patients, blood samples can be useful, but only in that setting. And combination of all the methods gives you best sensitivity, fastest results, and safest patient care. But remember, mold-active prophylaxis may impact the sensitivity. Now, what points do I consider when I choose an antifungal? Of course, if you know the diagnosis, it's slightly different. And let's now assume you have a pretty good idea what the diagnosis is. I'm still thinking, is it really a fungal infection? Is this colonization? Is this infection? Are we barking at the right or wrong tree? And if it is, which one? Could there be a mixed infection? Is yeast only approach enough? What is the site of infection and what is the tissue penetration of that antifungal to that site? We have loads of issues. The only antifungal that goes, for example, to urine is fluconazole. It goes there well, high concentrations, but none of the others do, which is an issue if you ever need to treat anybody with that. I think of activity against biofilms. So the antifungals are very different in that way. Your azoles have absolutely zero biofilm activity, cannot be used to treat, for example, endocarditis. What is the PK/PD issues? Drug-drug interactions, kinetics broadly, that I always think about that, and yeah, drug-drug interactions particularly, and other side effects. So these are the points I'm considering when I'm looking at it. So what do the guidelines say about candidemia management? So echinocandins are first line due to their generally broad spectrum within the yeast family, and activity against fungal biofilms. So they are biofilm active drugs. And that is so that they have better outcomes independent of the MICs that, so even in fluconazole susceptible isolates, if you treat with fluconazole, the outcomes are significantly worse compared to using echinocandins in the same, there are a couple of good clinical trials for this. We know that Candida parapsilosis is less susceptible to echinocandins, so that may be a question mark. And fluconazole is often seen that in this setting, fluconazole would be the right answer as the first-line drug. However, we have increasing problems with fluconazole and other azole resistance for parapsilosis. And again, there is no biofilm activity with fluconazole. Candida auris is typically multi-panazole resistant, and for B and echinocandins, the resistance varies between clades and strains. You may know your local outbreak strain, and that helps. But if you don't know, echinocandins are often first line, or combination therapy may be needed until you know. And remember, it's a biofilm forming fungus, Candida, and you need to source control and do your IPC stuff as needed. And this is about the tissue penetration of different, it's a really good review, recommend warmly to have a look and keep in hand. It's a bit out of date, isavuconazole is not on it yet, but tells you quite well what do we know about how the different drugs penetrate into different tissues. If there is a brain infection, if there is a bone infection, how do you think about it? And sometimes you do need to use combination therapy because you have multiple deep sites, and the penetration of one single agent may not be good enough to that site. So I just remind that there are rare yeasts. Candida is not the only yeast causing these infections, and there's a global guideline now for rare yeast infections. And you can see from this table that there is a column named avoid, treatments to avoid, and surprisingly, there are echinocandins are there mentioned quite a few times. So remember that for candidemia, echinocandins are first line, but definitely not for all yeasts. And if you're not sure, liposomal amphotericin B is a good safe option. Aspergillus treatment, very important to try to decide what you're doing. What is it proven probable, or is it really aspergillus? But for invasive aspergillosis, the recommended treatments are the voriconazole, isavuconazole, or liposomal amphotericin B. And azoles, when would you avoid them? Well, obviously, if it's a breakthrough infection on posaconazole or other azole prophylaxis, its cross-azole resistance is well known. Also, if there is biofilms, I wouldn't use azoles. If you are in a setting where there is high azole resistance, 10% has been in the Netherlands. They use 10% cutoff for deciding whether the hospital should use combination therapy empirically, and also in settings where you think you can't achieve the therapeutic levels. And this particularly children and others who metabolize drugs so quickly, combination therapy is often needed, or until you know you actually get there. And in case of some rare mold infections, so there is also a global guideline now for rare mold infections, and you can see that there is some variation from the voriconazole approach. With some drugs, some fungi needing alternative approaches. Useful tables when you run into these species that you can't even pronounce. And again, think of the tissue penetration. So how do we monitor treatment response? So repeat the tests that contributed to the diagnosis on the same sample types, with the caveat of for example, galactomannan becoming negative very quickly and can give you a false feeling of safety and response. Do we know what the best retesting interval is? But we would say it's once in every 1 to 2 weeks. It's not a CFP that you need to repeat daily or something. It's more important to have quality samples and do it every 1 or 2 weeks properly, rather than sending just something over all the time. Focus on the quality rather than the quantity, and depending, of course, the patient, how they clinically are doing. Remember that blood galactomannan is of limited benefit, even as when it was positive to begin with, and blood beta-D-glucan is not good. It can remain positive for a very long time in hematology, up to 4 weeks, and doesn't tell anything about the treatment response. It can also reflect antigens that have saturated the circuits, filters or ECMO or something. So just take it. I wouldn't use it for monitoring treatment response. But I must say, though, that if it stops going up, it's a good sign. Just a reminder, this is a table about lots of antifungal drug-drug interactions. Nice review, take the reference up. So good summary of drug-drug interactions and what they actually do and how you can live with it. We often think echinocandins are easy ones. They do come with drug-drug interactions. Anidulafungin may be easiest of them, and then you know that resafungin, which is the just registered long-acting anidulafungin, basically is basically a modified anidulafungin. Only a couple of words about the new antifungals that are coming. They definitely tick a lot of boxes in area of gaps with current drugs. So I've talked about the many species, Aspergillus species that are innately resistant to azoles and current treatments. There is a lot of activity there. Olorofim is absolutely amazing, a long list of things. But then your mucor and mucorales infections, rhizopus and others, we're not getting much help there yet with these either. Fusarium and others, you can see that that's not where the help is from these, but candida infections definitely. Olorofim has no candida activity, so if you ever use it, you do have to use it in combination with fluconazole, for example. So what can we do to improve patient outcomes? Well, we have to have the multimodal approach. That's what I've been saying all along. You have to think of mixed infections, and you do need to do TDM for your azole antifungals to know that you're treating. You think of biofilm surgical interventions, they are critical, and then consider combination therapy when you don't know what you're doing. Audit patient management and outcomes, definitely, and there are amazing tools for this. So the equal, this is the Aspergillus one, but there's Candida one, there's one for every bug more or less, and easy card to give to your trainees and do your audit. And it's been published well, that's the higher the score, it associates with better patient outcomes. So that's all from me today. Sorry, was longer than I thought. But yeah, happy to take questions now.
Thank you very much, Rena. That was an excellent presentation. And I could listen to you talk all morning or all afternoon, but we are at time, but there are 4 questions. So if everyone's happy, we'll take another 5 minutes just to go through those. Is that okay, Rena?
Yep, yep.
And I'll ask you my questions later because I've got some as well. So the first one is anonymous. Can you please elaborate the differences between colonization and infection?
Okay, my short answer to always is that if you're talking about something which is like candida in the mouth, in vagina, it's the underlying mucosa that decides. Angry skin, angry mucosa, that's infection. Happy skin, happy mucosa, that's not infection, that's colonization. Similarly, in lungs, I would say the same. You can have transient if the underlying lung, the airway is happy, it's colonization. Tricky sometimes, but in principle, host decides.
Great, thank you. And then from, I'm hoping I'm saying it right, Benjamin Buthorn. Very nice and comprehensive webinar, thank you. When it comes to diagnosis of invasive candidiasis, candidemia per PCR, which sample type is usually most appropriate? Literature is sometimes not conclusive whether whole blood or serum or plasma may yield best results, compromise regarding sensitivity and specificity.
Yeah, so actually, so I'm a member of the Fungal PCI Initiative Working Group, which is exactly looking into this. I don't have the answer to you yet. That's the short answer. The longer answer is that it also seems to, as far as we've gone, it seems to depend on the kit and the extraction. So it's actually going to be difficult to have the perfect PCR protocol because it has so many moving parts and they together contribute to the best sensitivity. But it's hopefully out in a year, I think.
Okay, so presumably it's whatever your reference laboratory or the laboratory that does the testing
You have to
recommends.
trust that they know what they're doing. If you're running it in-house, yeah, validation is a challenge.
Okay, thank you. And another anonymous, what is the utility of 18F FDG PET CT for diagnosing invasive aspergillosis for this patient group?
So we do use PET CT, obviously, when we're not sure how disseminated infection is. And often that is in a scenario where we think we have treated what the problem is, but the biomarkers are not coming down. Patient is still unwell and you're not sure what's going on. 18S, so just as a mycologist, I have to correct there. 18S is it won't work, or it's very limited. So you have to use at least 3 primers, not just 18S for. So therefore, the proper term for that is what you're talking about, is panfungal PCR. So we have multiple targets, and then you get the sensitivity and specificity you need for sequencing. So panfungal the usefulness of panfungal, I'd say it is irreplaceable. At the moment, we are finding it detects new fungal species, new pathogens. It's an open question. What is this? You have a good sample, tissue, right kind of sample. It's irreplaceable, extremely useful.
Thank you. A treatment of candidemia, you advise a echinocandin, but if you know it's albicans, particularly if the patient is treatment naive, could you start with fluconazole?
Never, because fluconazole doesn't have any biofilm activity, and Candida forms biofilms within hours. And every patient who has candidemia would have lines in, would have all sorts of things. So there will be biofilms somewhere. So never. And clinical trial data shows very clearly that it's inferior to echinocandin independent of the MIC.
Thank you. Yeah, I think most of centres in the UK would give an
That's the
echinocandin.
guidelines. Yeah.
Yeah. Is it possible for Candida infection to develop into cancer in the body?
My favorite topic. I published a lot on this. Yes. Yeah, Candida produces. So Candida, we know alcohol-related carcinogenesis is not because of ethanol. It's because of one of the metabolites, acetaldehyde, and Candida produces alcohol. It produces acetaldehyde, which is class 1 carcinogen. So chronic Candida infections in the mouth, for example, they are carcinogenic.
Thanks. We're getting a lot of them, so we might have to wrap up soon. And then if you're happy to answer those questions, because we've got names for the next people, so that's a bit easy. But do you have any experience of using antifungals in cement for bone and joint infections? Is heat deactivation a problem?
So yes, in Desperacy we have, and we've used mainly voriconazole for this purpose. Exactly, it may be, but in Desperacy, no evidence. I wouldn't. It's the last resort, not the routine thing to do.
Okay. Thank you. And thank you very much, Rena. We have 3 more questions, but if you're happy, Rena, if you
Yeah.
can respond to them after presentation, just in the interest of time. So I'd like to thank Rena Richardson for an excellent presentation today. And I'd like to thank all the attendees for joining us, and I hope you found it very useful. Recordings will be available on the RC website in the coming weeks. Thank you.
Thanks.